All right. Well, good afternoon to everyone, and welcome to this month's INCORE Connect and Explore webinar. Our topic today is nutritional implications of GLP-1 medications in obesity care. And in just a few minutes, we'll be getting to today's presentation. And after that, there will be a chance for Q&A, and we will close out with a few quick announcements. My name is Karen Hilliard, and I am from the NCORE Coordinating Center, and I will be your facilitator for today. And I would like to introduce you to today's speakers. So Sandra Christensen is the founder and owner of Integrative Medical Weight Management in Seattle, Washington. She is board certified as a family nurse practitioner and holds the certificate of advanced education in obesity medicine from the Obesity Medicine Association. Ms. Christensen is a master fellow of the Obesity Medicine Association and a fellow of the American Association of Nurse Practitioners. She serves on the board of trustees for the Obesity Medicine Association and is the president of the Washington Obesity Society. Ms. Christensen is an associate editor of the journal Obesity Pillars and authors peer-reviewed articles on the topic of obesity. Jamie Almondas is an associate professor of internal medicine and the medical director of the Weight Wellness Obesity Medicine program at the University of Texas Southwestern Medical Center. He is board certified in endocrinology and internal medicine and is a part of the American Board of Obesity Medicine, where he currently serves on the board of directors. His research focuses on obesity pharmacotherapy, disparities in obesity care, and post-bariatric weight reoccurrence. He also serves in leadership roles within the American Association of Clinical Endocrinology and the Obesity Society. So welcome to both of our guests. We're very excited about your presentations for today. Before we get started with the presentations, I just want to go over a couple of housekeeping notes for everybody who is joining us today. If anyone needs technical assistance, you can let us know using the chat box. And if you're having trouble logging into the webinar, please email us at incor@fhi360.org, and we'll work with you to resolve the problem. If you have a question for our speakers during the webinar, that you can put those in the Q&A feature at the bottom of your screen. And we encourage you to put those questions in all along during the presentation. We'll be collecting them so that we can get underway with the Q&A once our presentations are finished. And I also wanted to let you know that we will be tweeting today's webinar from the INCORE Twitter account or X account. And to join the conversation, you can use the hashtag ConnectExplore. Also now, it is often helpful for our speakers to know a little bit about who is in the audience. So for all of you joining us today, we have a question for you. So you'll see a poll pop up in just a moment, and if you can answer this question: what profession or sector do you identify with? And you can select all that apply if you fill more than one role. Are you a researcher? Are you in federal program management, a clinical registered dietitian, nutritionist, in public policy? Are you a student? Is this more general interest for you, or maybe some other category? So I see a lot of folks answering the question, and we'll give everyone just a moment and then end this poll in just a minute. I think most of the votes have come in now. Again, it's very helpful, especially as we get into the Q&A, to know who's in the audience so that the questions can be tailored for the things that you are most interested in. All right, we can go ahead and end this poll and share the results here. So you can see that we have quite a mix of folks. About 40% of you are researchers. Nearly half of you are clinicians or registered dietitian nutritionists. We have a number of folks in federal program management and public policy, and also some students joining us, and then some other folks in the general interest category, and maybe something else that wasn't listed here. So thank you so much for letting us know where you're coming from, your perspective, and that will give our speakers a better idea of how to tailor their comments. And so now I'd like to turn things over to our speakers and go on to today's spotlight: nutritional implications of GLP-1 medications in obesity care. And I'm going to hand things off first to Sandra Christensen to talk about nutritional risks associated with the use of GLP-1s.
Thank you, everyone. It's great to be with you today, and it's good to see that there are a strong showing from clinicians and RDNs, as well as researchers. Next. So these are my disclosures. Next. So our objectives today is, first, we want to just recognize the importance of approaching obesity as a disease, in particular during GLP-1 treatment. Obesity is a disease, weight loss is not. And so we really want to be thinking about this chronic disease that requires long-term treatment rather than just helping people lose weight. And then secondly, identify the nutritional risks that we see with GLP-1s during obesity treatment. And I'm going to really focus on across the lifespan. And then also identify the research gaps regarding nutrition and health status during GLP-1 therapy for obesity. Next. So the first question that we really need to talk about is why it's important to approach obesity as a disease during GLP-1 therapy, and how we can kind of set things up well from the beginning. Next. So as I mentioned, we want to see it as a disease, and we want to focus more of our treatment on the outcomes and not just the weight. And we know that health outcomes improve when folks get a really good assessment from the beginning. So before we even get them started, we want to know their weight history, their nutrition history, medical history, what their current nutritional status is. We want to do a comprehensive exam to look for any complications of obesity, and in particular, muscle function, and body composition. And then for women that enter into the perimenopausal years, and even slightly before that and beyond, we want to know what their bone density is so that we can make sure that the therapy does not reduce that. Then we want to provide them with nutritional counseling. And I'm speaking just to the nutritional needs, but we also want to give them physical activity guidance, et cetera. And then we really need to monitor folks closely. So we know what their nutritional status is, what their intake is, what side effects are they experiencing, and how is that affecting their nutrition, the weight reduction, their body composition, their functional status, so the muscle quality, and their ability to perform their activities of daily living, and then any health changes or improvements. Next. So we'll start by talking about what the nutritional status of people with obesity is and why that's important. Next. So we know that people with obesity are predisposed to having nutritional deficiencies, and it can contribute to further weight gain for them or the development of other metabolic diseases. And we know that people with obesity have a higher consumption of ultra-processed foods. It's more common for them. And then they also can have micronutrient deficiencies. And this can result from people that don't have adequate access to nutrition-dense foods, to making incorrect dietary choices. There can be some interference with the absorption and distribution or excretion of nutrients. And then the systemic inflammation caused by obesity can alter the micronutrient metabolism. Next. So for folks with obesity, we often see these micronutrient deficiencies estimated average requirement for vitamins D, and more than 15% don't meet it for folate. And then there's a 5 to 12% lower intake of calcium and vitamins A, C, D, and E. So that's pretty substantial things that we need to be aware of before therapy starts. Next. So now we want to talk about the nutritional needs of folks across the lifespan. Next. So teens, you can see here that 0.8 to 1 gram of protein per kilogram of body weight, and that would be an adjusted body weight. If they're involved in power sports, that goes up, almost doubles, 1.5 to 2. And we don't have any information about the protein needs for teens with obesity. Next. So many women can spend 40% or more of their lives in a menopausal state. And so this is a really important group for us to really understand their needs and what the results can be from these medications in obesity treatment. And it's really important that we think about even the changes within that spectrum from perimenopause to menopause. And these are the majority of our patients tend to be women, kind of 40 and up. And so that's why this is a really important topic, both for clinicians and researchers. So we know that in menopause, there's some partial anabolic resistance to dietary protein, and that can prevent muscle protein synthesis as well as bone protein synthesis. And this can even start in the early stages of menopause. And so for women and for men as well, as they get older, their protein needs actually go up because their body isn't utilizing the protein as efficiently as it does when they're younger. And then another thing we often see is a decrease in physical activity, and then that can contribute to this resistance to dietary protein. But what we do know is that when protein is more concentrated in the diet, that really helps people to reduce their energy intake. So they're getting more protein, vegetables and fruit, and less of the ultra-processed foods. Next. And then we also, the protein needs of older adults with obesity go up. And so healthy adults, it's 0.8 grams per kilogram of body weight. But for folks that are 65 and older, to maintain and regain the muscle mass that they lose each year, they need 1 to 1.2 grams of body weight. And then those with chronic diseases, 1.2 to 1.5. And so anybody with obesity has a chronic disease, and so they're going to need the higher end, and they may even need more beyond that. Next. So let's talk about how GLP-1s impact eating. Next. So this is a review article that I wrote with 3 of my colleagues, and we wanted to understand what the dietary intake is of patients taking GLP-1 and dual GIP, GLP-1 receptor agonists. So that we could determine what the research needs are and what their nutritional needs are. And so we reviewed the current literature. Next. So in this, we looked at 10 studies, narrowed it down. We looked at what medication they were on, the dose, the delivery, the timing, if they were getting any dietary recommendations, and the duration of their treatment. And so the study outcomes that we included were the data collection on what was their dietary intake, how was that assessed, was it self-reported data, was it food diaries, was it photos sent to the researchers, and then what was the duration of the dietary intake versus the comparative, with the focus on really evaluating the energy and nutrient intake. And then looking at the subjective data that participants reported on their appetite, cravings, and food preferences, and then if an RDN was involved. Next. So the medications that were included in these different studies were liraglutide, the 1.83 milligram subcutaneous doses. Those are for the diabetes and then the obesity indication. Lixisenatide, 20 micrograms subcutaneous, diabetes med. And then semaglutide, the 14 milligram. This is the oral form that's indicated for diabetes. And then semaglutide 1 milligram SQ. So that was what was available when these studies were done. That was the maximum dose available for diabetes at the time. And then semaglutide 2.4 milligrams, which is the obesity dose, and then tirzepatide 15 milligrams SQ. Next. So the results showed that their caloric intake was reduced by 16 to 39%. And very few of these studies reported anything about the composition of the diet, so we didn't know much about their micro or macronutrients. Many of the participants reported changes in their preferences for certain foods, either more or less. And then only 4 studies evaluated the macronutrient intake in addition to the change in the energy intake. And then only 2 out of 10 included an RDN. Next. So the conclusion we came to is that we need further research so that we can understand the unique nutritional needs of adults on these medications and to support the development of nutritional guidelines going forward. Next. So what we know about these meds in terms of nutrition is that they reduce appetite, they increase satiety, and often decrease food cravings. And we don't really have any data on this for people that are on the compounded forms of semaglutide and tirzepatide, but some anecdotal evidence shows that it might have some similar effects. Next. So this is what I see clinically every day, is that folks are just less interested in food. They have less of the food noise, which is this preoccupation, thoughts of food, thoughts of finding food, eating food. But they also have less enjoyment and pleasure for food, which is a plus and a minus. Some can have food aversions. Those tend to be worse at the beginning of therapy and with dose increases. For some, it never levels out. For others, it does. And some people are so relieved to not have to think about food so much and to have it kind of move out from their central vision to their periphery. But others find it to be this profound loss, and there's some real grieving that goes on for them. And they can be ambivalent about whether they want to be on the med or not, because they like the effects, but then they've lost this source of pleasure. And these changes can really make it challenging for people to be interested in planning, shopping and preparing their food and then eating their food. Next. So some additional observations that I see and concerns that have arisen are that when folks feel nauseous, they often crave those comfort foods, so the more sugars and refined carbs. Kind of dating back to childhood. I mentioned the food aversions and how those can fluctuate. And then I also mentioned this limited interest in food and not having hunger. So people can just go several hours without eating. It doesn't even cross their minds. Some people see that as a really good thing, not recognizing that they're not getting enough nutrition. And so that's the risk, is they don't get enough. And then if they go too long without eating, they'll get these rebound preferences for sugar and processed carbohydrates. And so that's why it's really important that we have our patients eat pretty regularly throughout the day. And then, as I mentioned, they can feel this frustration that they've lost a quality of life because they're not getting as much pleasure from food as they used to. And for some, that can lead to discontinuing the medication. Next. So what I see a lot is a change in the preference for certain macronutrients. Some folks that are already enjoy eating protein, it doesn't seem to affect them. For others, it can be really decreased, and that can be problematic. Some can have more affinity for sweets and starches, and others it can really reduce it because it's reducing the cravings. And the side effects of nausea and vomiting can really influence preferences for certain foods. I see a lot of folks that have much less interest in alcohol, and they don't seem to tolerate it as well, especially older folks. And then they don't seem to have as much thirst, and so their fluid consumption can go down, and that can contribute to them being tired and nausea as well. So there's benefits and drawbacks to these changes. Next. So in terms of cravings and disordered eating, lots of trials show that there's less of both. And so there's that less food noise we talked about. We'll see less emotional eating, less, they're better able to resist foods in the environment that might be tempting. We see less binge eating and some similar effects on eating control and symptoms of food addiction. Next. So what are the nutritional concerns that we have? Next. So there's concern about people just getting undernutrition. And so when we see that large and rapid caloric restriction down to less than 1,200 calories for women and 1,800 for men, and this, of course, can lead to some insufficient intake of vitamins and minerals. And then the GI side effects can further compromise the absorption and can exacerbate nutritional deficiencies. Next. So also not getting enough macronutrients, inadequate micronutrients, inadequate fiber, and then a reliance on simple carbohydrates and ultra-processed foods due to that suppressed appetite, less interest in food, food aversions, nausea, and wanting just something that's easy to eat. Next. And then there's the concern about not having enough protein to maintain their muscle mass, strength, and function, because rapid reduction from these meds can lead to both fat and muscle loss. And 11 to 50% of the total weight reduction might come from the loss of that lean body mass, including skeletal muscle. From the STEP 1 trial, there was a post hoc analysis that looked at the semaglutide 2.4 milligram dose and saw that 20% of their weight reduction was from muscle. And then the SURMOUNT-1, which is the tirzepatide, another post hoc analysis, showed that the muscle loss varied by sex. So it was 10 to 15% of the weight reduction for women and 20 to 25% for men. So greater there. And none of these people were doing any kind of structured strength training. And then also people that hit the reduce the weight without exercise are also at risk of muscle loss. Next. And then the last concern that I'll bring up is bone density. Enough protein, it's going to contribute to bone loss. And so a rapid reduction of weight from these meds can contribute to that. And so any substantial weight reduction greater than 14% or that's rapid over 3 to 4 months is associated with some significant bone loss. And so we think that moderate and slow weight reduction might be better in preserving the bone mass. And then, of course, women and older individuals are going to have greater bone loss. And then intermittent use of the meds or weight cycling can exacerbate that. And there's one trial that we have, so we don't have a lot of data. It was a randomized trial, 1 year of combining GLP therapy with exercise, showed that it preserved bone mineral density, and those that just did the therapy alone had decreased bone mineral density. Next. So what are the data gaps and research needs? Next. So this is my summary, and I want you all to think about people, teens, women preconception. We don't know how this could affect them. Perimenopausal women, postmenopausal women, and then older adults 60 and up. And thinking about what their unique nutritional needs are during therapy, and then how the GLP-1 therapy affects their body composition, so primarily their fat, bone, and muscle. And then how does it affect their current and future functional status? And then what is the effect of one therapy on eating disorders and disordered eating? And it would be valuable to know more about all of these things also for folks on the compounded GLP-1s, as well as folks who've had bariatric surgery, because we often layer therapy on top. Next. Thank you so much. That's the conclusion of my presentation. I'm going to turn it over to Jamie now.
Thanks so much, Sandra. That was a great talk. Okay, good afternoon, everyone. Thank you so much to the organizers for inviting me to present today. Next slide, please. Here are my disclosures. Next slide. So what I'd like to outline for my portion of the presentation today is to describe some of the body composition changes seen during GLP-1 receptor agonist treatment for obesity specifically. Discuss clinical assessment of physical function and how it changes with GLP-1 therapy in people with obesity, then to review common GI side effects and adverse effects and strategies to improve tolerance, adherence, and clinical outcomes as part of that. Next slide, please. So I think it's important for us to kind of frame this in terms of what's going on in the world of obesity care. And I think so much of it is driven in a very different way to, say, cardiovascular care or diabetes, when we're talking about kind of consumer drive and desire and their own definition of goals of success. And when we look at results from things like the Observe study, which surveyed people living with obesity to determine what magnitude of weight change they would like to see and be satisfied with, if we think in the context that we typically see somewhere between 3 to 7% non-sustained weight reduction with interventions like lifestyle modification alone, and we look at the results here, for those who were disappointed, the median weight loss would be somewhere around 5%. So typically what we recommend in terms of, have you considered eating less and moving more, will leave most people disappointed with regards to outcome. The goal for most people is a median weight loss somewhere of around 16 to 7% with a range of 10 to 25% weight reduction, with the dream weight loss about 24%. The average person who comes to see me in clinic in Dallas says that they'd like to lose around 30% of their body weight and they're living with a BMI of 40. There are, of course, nuances with regards to who prefers greater magnitudes of weight loss, women more than men, those with higher BMI and self-reported weight stigma, also Hispanic participants relative to non-Hispanic white participants. So there's some nuance with regards to where it is that people would like to be from a weight perspective. Next slide, please. We're fortunate to have a variety of different agents. The older first-generation agents, such as orlistat, which worked as a pancreatic lipase inhibitor, blocking absorption of fat, phentermine by itself or with topiramate, working as a sympathomimetic in combination with GABAergic agents, or naltrexone bupropion, working on kind of hedonic drive and reward pathways, kind of helped most people to lose somewhere in the region of 5 to 10% body weight on average. With newer type agents, including incretin-based therapies, GLP-1 receptor monoagonists, and dual GIP receptor agonists, liraglutide being the first, followed by semaglutide and then tirzepatide, these work in different ways that mimic kind of natural kind of protein physiology in the fed state to tell the brain that we've already eaten, to signal to the stomach that we are in a digestion and absorption phase. So there is kind of induction of satiety centrally, reductions in appetite and cravings, and then changes in gastric motility and emptying that really promotes satiety and being satisfied with less food for longer. With regards to approvals for these medications, specifically GLP-1 and GIP-GLP dual agonists, these are approved Lira and Sema for those 12 years and older, and for tirzepatide, those 18 years and older. Next slide, please. When we look at magnitude of weight loss, I kind of shared the change we typically see with the older generation of obesity medications towards the left-hand side of this figure. And towards the right with semaglutide and tirzepatide, what we see is this gradual bridging of the gap between magnitude of weight loss that we see with lifestyle modification versus bariatric surgery, with semaglutide about 15% weight reduction in people without diabetes, and tirzepatide close to 22%. Next slide, please. But I think what's important to acknowledge is that there's a heterogeneity in terms of response to any kind of weight reduction intervention, be it lifestyle modification, be it bariatric surgery, or GLP-1 based therapies. And what we see here is kind of the almost normal distribution of categorical weight loss outcomes for people treated with liraglutide, semaglutide, and tirzepatide for obesity. And to the left of the dashed vertical red lines, what we see are people who did not lose any weight or in fact gained weight as part of the studies. And I just want to kind of highlight kind of the heterogeneity, not just in terms of weight loss response, but in terms of cardiometabolic response and in terms of adverse effects experienced and reported as part of treatment. Next slide, please. Something that's been kind of talked about a lot in news and research recently, and Sandra touched on it just now, is changes in body composition. This figure shows reported changes in body composition with calorie restriction, either with focus on high protein diet or with diet and exercise. And we kind of see a relative sparing of loss of skeletal muscle mass or lean mass as a component of fat-free mass versus fat mass. And I say that to kind of clarify that there are a variety of different terms that often get used both in the lay press with patients in exam rooms or when we're reporting our findings that can sometimes be confusing and misleading. Next slide, please. There's a really nice review article by Prado and colleagues in AJCN that was published, I think, last month, which does a really nice job of outlining the definitions and utility of different measures and assessment for looking at body composition in people with obesity at the molecular, cellular, tissue, organ, and whole body levels in a way that can help us to understand and report and explain these findings in a way that doesn't create confusion. So much of the results are often expressed in terms of fat-free mass or lean mass relative to fat mass, but there can be confusion if we then conflate fat-free mass as skeletal muscle mass itself. Next slide, please. For the non-clinicians on the call, just kind of a quick outline of what happens when we start semaglutide and tirzepatide from a dose perspective. Semaglutide on the left, what we see is that there are 5 different doses, and tirzepatide on the right, there are 6. The product insert type instructions will be to increase the dose every 4 weeks or as tolerated to the maximum tolerated dose. In terms of doses that are approved for chronic therapy, semaglutide is the 1.7 and 2.4 milligrams, whereas with tirzepatide, it's the 5, 10, and 15 milligram doses. So you can see that in order to get somebody up to the kind of the maximum available dose for semaglutide, we're talking about 20 weeks or 24 weeks with tirzepatide. Next slide, please. And I want to highlight here the magnitude of weight change that we will see during that dose titration period. So if we look at this figure here, and these are results from the SURMOUNT-1 study for people with a history of obesity without type 2 diabetes, treated with 5, 10, and 15 milligrams of tirzepatide once weekly. And to kind of highlight the first 24 weeks being the dose titration period for the 15 milligram curve, we can see that people lose about close to 2/3 of the average weight loss within that 24-week titration period as that dose is going up. So you can imagine that there's quite a lot of changes going on with regards to energy balance and in particular energy intake during this first period and during this titration period. If we kind of look out, and this is kind of maybe kind of going off a little bit off topic in terms of how long it takes to achieve maximal weight reduction, in looking at 3-year tirzepatide data, one study suggested that the median time to nadir body weight was 99 weeks. This study here only goes out to 72 weeks. So I think that's important to keep in mind that the duration needed to see maximal effect of these obesity management medications, but also the magnitude of weight change we can expect in a relatively short period of time. Also, next slide, please. And I think that's important because much of this, the reduction in body weight, is coming from a reduction in energy or calorie intake. If we look at the two panels towards the right-hand side of the slide for tirzepatide 10 milligrams and semaglutide 2.4 milligrams in this paper by Kevin Hall, what we can see modeled out is a reduction of about, so let's say, 1,000 to 1,200 calorie reduction or deficit of energy intake from baseline at 3 months during kind of that period of rapid weight reduction. And we've talked in other forums before with regards to kind of quality of nutrition, unfortunately, for most people living in the United States. And you can imagine that an unguided reduction in this magnitude of calorie intake could potentially lead to an exacerbation of both existing nutritional deficiencies or creation of new ones, unless close attention is paid to dietary quality, perhaps targeted repletion, and perhaps empiric supplementation to prevent deficiencies, none of which we really have data for. Next slide, please. When we look at studies that report the kind of changes in body composition with treatment, this paper here kind of highlights that with these three kind of agents, tirzepatide, semaglutide, and phase 2 data from retatrutide, which is a triple agonist for GLP, glucagon, and GIP, we see reductions in that fat-free mass somewhere between 25 and 39% of the weight loss was non-adipose mass. But if we kind of flip to the glass kind of half full, we can see that 61 to 75% of the weight loss was adipose mass. Next slide, please. The question is, well, is this a good thing or a bad thing? When we look at the relative change in the panel on the left, what we can see is that after an intervention, these are data from the SURMOUNT-1 study using DEXA, we can see that the participants on average started off with about 48.2% body fat, and at the end of the study, they ended up with 40.8% body fat, which means that there was an increase in fat-free mass from 51.8 to 59.2. So we see an increase in fat-free mass of 7.4%. But when we look at the right, there was an absolute loss of lean mass or muscle mass, excuse me, of about 6 kilograms. So is that problematic and is this harmful? And again, these are data we don't have robust kind of explanations of how we can contextualize, is this something that is problematic for people living with obesity or specifically for certain subgroups within that? Next slide, please. To try to answer this, there have been some subgroup analyses of the data stratifying by things such as age, with the thought that older adults may be more at risk for loss of lean mass or sarcopenia. When stratified by age, in the panel on the left here, what we can see is that there appears to be kind of similar kind of magnitudes of lean mass loss relative to fat mass loss across groups. Apart from it looks like a little bit more lean mass loss in the placebo group who were over 65. When we look at the lean mass kind of change from baseline on the right-hand panel here, we can see that about 10 to 11.3% loss of lean mass, and that seems somewhat consistent throughout the stratified age groups. But again, it's important to contextualize that I think it's every year after age 40, I think we lose something like 3% of our lean mass. So people who are older are likely at a disadvantage, even though they are losing relatively similar magnitudes of lean mass as part of this. Next slide, please. The thought is that incorporating things such as higher protein intake, as discussed by Sandra previously, and physical activity can be helpful to prevent this loss of lean mass that's undesirable and to attenuate the risk of weight recurrence. Next slide, please. When we try to kind of extrapolate out, well, does loss of lean mass lead to perhaps changes or worsening of physical function for people with obesity as part of this journey? Well, the data that are collected in terms of SF36 data, physical component score, physical function domain, and kind of the physical domain, the row physical domain, really kind of show that there are improvements in physical functioning with the weight change and with the body composition changes observed in studies such as the SURMOUNT-1. Next slide, please. When we look at changes in physical component score by magnitude of weight loss, we can see that there's kind of a dose-response relationship where those who lose 20% or more of their body weight see the greatest improvements in their physical functioning scores, whereas those who lost no weight or who gained weight, who lost no weight, or less than 5%, saw a reduction in their physical functioning scores. Next slide, please. And I think what's important when we look at data, and this is now data from step 1 with semaglutide, and we look at people who had baseline poor functioning to see if those people experienced a worsening in their functioning scores, those were the ones who saw the greatest improvement. Next slide, please. And so I think it's important to note that baseline assessment is really important, and that physical function measures such as things like muscle strength, physical performance such as gait speed, chair rising, sit to stand, and body composition, unfortunately, is not being done in the majority of people who are being assessed for obesity or being prescribed powerful obesity management medications. We need to do a better job of identifying those at risk for sarcopenia and frailty, determine appropriate cadence for monitoring during therapies, integrate resistance and adequate protein intake, but to determine what the appropriate doses are for both of these across different age and other at-risk groups, and address social determinants of health and how these interact with risk for adverse outcomes with these medications. Next slide, please. And so I think it's important for us to look holistically at kind of nutritional considerations with this. And this is a paper that several of us authored with regards to constructs for how to turn this into a chronic disease management type model of care with assessments and monitoring of treatment. Next slide, please. It's important to make sure that we are performing thorough baseline assessments. As Sandra shared, many people living with obesity have inherent risk for malnutrition, and it's important to make sure that we are not going to exacerbate this in the course of treatment. Make sure we incorporate appropriate dietary modifications, and make sure that we also dose these medications appropriately. The goal of obesity care and obesity management medications is not to get to the highest available dose as quickly as possible. It is to start the appropriate medication for that patient and titrate the dose to the appropriate response, be it changes in body weight or cardiometabolic responses, deciding if we need short-term medications for symptom control, dietary modification, or dose adjustment to avoid discontinuation of medications that may be otherwise helpful for that patient. Next slide, please. When we look across different studies for GLP-1 adverse effects, we can see that kind of nausea is kind of one of the principal things, followed by diarrhea, potential for vomiting, and constipation, which is also likely associated with overall treatment discontinuation. Next slide, please. And this is a concern across multiple studies for people taking GLP-1 medications, both for obesity and for type 2 diabetes, with less than half in many series off of the medications by 1 year. Next slide, please. And that's important because we know that there's also weight recurrence that occurs with cessation of these medications. Studies would suggest about 2/3 of the lost weight is recurred by 1 year after discontinuation. But beyond that, there is recurrence of other cardiometabolic risk factors, such as prediabetes, hypertension, et cetera, which are successfully treated with both the weight reduction and these agents. Next slide, please. And I think it's important for us to work out if gastrointestinal issues are something that are precluding adherence and persistence with these medications, how can we best address these? There are several papers that I'll kind of direct you to in the interest of time that do a really nice job of having practical algorithms for assessment and treatment. Next slide, please. In addition to looking at both over-the-counter remedies, prescription treatments, and also dietary modifications to help to support patients on these medications, understanding that there's often a dose-response relationship to side effects and an interaction with dietary habits that can be monitored if we are seeing patients back and assessing them appropriately and providing individualized advice. Next slide, please. There are studies recently showing that flexible dosing, so not the kind of forced titration of study protocols, is associated with a reduction in adverse GI side effects and promotes adherence and persistence with these medications. So more flexible dosing can be something that is useful to mitigate potential adverse side effects that can contribute to discontinuation. Next slide, please. And I think this is really important because over the last several years, I'm sure many of you have been bombarded with advertisements and questions with regards to the use of compounded agents for this. And I think, unfortunately, it has normalized access to very powerful drugs for obesity that can cause significant reductions in appetite and intake without the need for standardized medical assessment and follow-up in a way that supports optimal health outcomes. The goal of obesity care is improvement in health and quality of life, not simply just reducing weight as quickly as possible. And so I think it's important for us to explore how can we support this? Can we put some of this toothpaste back in the tube with regards to patient expectations for what obesity care needs to look like, but also to support the research that's needed in order to get these things covered by policy and other avenues that are so important for evidence-based care reaching our patients. Next slide, please. So it's important to note that many societies have gotten together to support the kind of integrated role of lifestyle and nutrition, including this joint paper by several societies that, in the interest of time, I'll just direct you towards. Next slide, please. And there are several gaps here, many of which Sandra touched on, including kind of how do we support dynamic recommendations for nutrition and energy intake? How can we support this across the lifespan, including children, given the rise in pediatric obesity? Should we look at empiric versus targeted nutrition support or supplementation? What is the kind of particular situation for considerations for bariatric and other patients, and how can we integrate technology and artificial intelligence into creating individualized plans of care for our patient? Next slide, please. So finally, just to wrap up and highlight that highly effective GLP-1 therapies really decrease energy intake that can increase the risk for nutritional deficiencies and loss of lean mass. And it's important that we have guidelines for baseline assessment and individualized nutrition plans to support adequate nutrition and decrease risk for malnutrition and adverse changes in body composition. GI side effects are common and can contribute to malnutrition and potentially adverse outcomes with regards to body composition. And we need to work out the correct integration of dosing and nutrition therapies for this. There are significant gaps for evidence-based guidelines for nutrition assessment and supplementation and support therapies that I encourage you all to explore as part of this. And comprehensive care is key. Patients who receive GLP-1 receptor agonists without appropriate guidance may be at risk for nutrition misadventure, discontinuation, and unintended health consequences. With that, I'd like to thank you all for your attention.
Thank you so much to both of our speakers for a terrific presentation. We have a number of questions and we'll try to get to a few of them before it's time to wrap up today. Let me go to the first one here. The first question is, I have a lot of patients who end up with really low appetite. What would you say is a concerning level of calorie intake? And would it be similar to bariatric surgery goals? And either one of our speakers can jump in there.
I can start with that. I think it can be really challenging when patients come in and they report that their calorie intake is very low, but sometimes the weight is going down in parallel and things are tracking, but sometimes it's not as well. And it's working out, when do I need to be concerned? I think trending the weight, talking with our patients about functional symptoms of fatigue and other things that would make us concerned, weakness, things that they're not able to do, perhaps objective functional assessments done serially in the office, in terms of kind of what to do, making sure that they are hitting appropriate milestones with regards to nutrition intake, as Sandra really nicely outlined, is really important in order to work out, is this something that's worrisome versus not? I don't have hard and fast rules because I find that sometimes patient recall can be challenging in situations, not to undermine what they're reporting, but making sure that if they are feeling that their nutritional intake is inadequate, adjusting the dose downwards rather than trying to force feed them and induce nausea is an important interplay of what to do when people are on GLP-1 therapy.
Sandra, do you want to add anything?
Yeah, I really support that. And what Jamie is saying is really individualizing therapy, right? Like making sure that the function of the person is adequate. And that's what I primarily focus on. I do have a lot of focus on them getting nutrient dense foods, so protein. And sometimes when they have nausea and or not interested in eating, providing them with examples of types of food they can eat that are easier to eat in those situations, right? Like, cottage cheese and yogurt and protein smoothies and those kind of things that can really help them get adequate nutrition. And as Jamie said, I'm not a rapid titrator. I like base it on, are they getting adequate nutrition? And I'll tell them we're trying to find this sweet spot where we're suppressing your appetite and cravings enough, but not so much that you can't eat enough to get the nutrition that you need.
We had a couple of questions also about, kind of what the data was based on, what standard. One of the questions was whether the data on micronutrient needs was just for adults. And the other question was whether the protein needs were based on the ideal body weight or adjusted body weight or actual body weight. So if you could address those questions, that would be helpful.
Yeah, I can do that. So all of the nutrition data was for adults only, except for that one slide where I provided the protein needs for teens, just their basic needs, and then if they're in kind of power sports. And then, there's a lot of debate out there.
I think we may have lost her.
Okay, I wasn't sure if it was on my end or not. Sandra, we may have lost you
No,
for a moment. Oh, I hear you.
we did. I
Okay.
apologize for that. So in my clinical practice, I use ideal body weight because for folks that are really heavy, like they just can't consume that much protein. It's just impossible. And so I use ideal body weight or adjusted body weight. Was there another question in there too?
Well, there's one last question, and maybe I'll throw this to both of you, and you can quickly answer because we're almost out of time for Q&A. But how long do these medication side effects last typically?
The most common side effects will be nausea and kind of gastrointestinal kind of bloating, those kind of side effects. And those are typically during the dose titration phase as well. And as Sandra's saying, by kind of individualizing titration, we can really kind of offset that and hopefully avoid any kind of major side effects. Most studies would suggest that they're kind of in the initial few months of treatment during the dose titration, particularly the first few days.
And I know there were a number of questions that we will that we hope that we can answer in a future webinar. But I want to we're out of time here for today, so I want to say thank you to both of our speakers. This has been a great presentation with a lot of good things to think about and consider as we move forward and as we look at potential for further research on GLP-1s. So thank you both again for being here with us today. And we have just a few announcements to close things out. I wanted to let you, everyone in the audience, know that if you'd like to learn more about obesity care, you can check out our obesity-related policy systems and environmental research in the U.S., also known as OPUS workshops. And we hope that you'll take a look for those online. We also want you to know that you can access past NCORE Connect and Explore webinars on our website at ncore.org. And some of our recent topics cover things like the impact of weight stigma on families and youth and the role of sleep in child health. We also want to call your attention to our next Connect and Explore webinar, and that is entitled Turning Evidence into Action, using NCORE's implementation scorecard to strengthen childhood obesity, nutrition, and physical activity interventions. And that webinar is scheduled for Tuesday, October 14th at 1 p.m. Eastern Time. And we'll explore the development of NCORE's new implementation science scorecard and how practitioners can spot both strengths and blind spots as they move through implementing new interventions or programs. Also wanted to let you know that you can sign up for the NCORE newsletter to get the latest updates on NCORE publications, tools, and resources, plus upcoming events. And you can sign up for that at the link that you see in the chat, ncore.org/e-newsletter. Also want to say for all of the students who have joined us today to be sure to check out the Student Hub webpage. And for that, you can go to ncore.org/student-hub/. And also, for any of you who have used any of NCORE's tools, we would love to hear about it. So please reach out to us. You can reach us at ncore@fhi360.org, and we'd love to hear more about them and maybe feature them in a future webinar. And also remember to follow us and like us if you don't already. NCORE is on LinkedIn, X, and Facebook, and you can find us in all of those places. We hope you'll check us out on the socials. And we also encourage all of you who have joined us today to take the post-webinar survey that's going to open up when this webinar ends. So please hang around to do that. Once again, I want to thank today's panelists for great presentations and so much to think about, and thank all of you who joined us today for the Connect and Explore webinar. Hope you have a good rest of your week, and we'll see you next month.